good in liver transplantation and other places also. Thank you, Arjun, for joining us. And the person presenting the case is Dr. Arun he's a third year PG of DNB in pediatrics in Gangaram Hospital. Arjun, over to you now.
Thank you, sir, for the kind introduction. So today we'll have Dr. Arun presenting a case of approach to jaundice on how to approach a child with jaundice. So without any further delay, we'll start with the case.
Okay, good evening, everybody. Good evening, sir. And I'm today presenting a case under the moderation of Arjun Maria, sir, and Dr. Nishant Wadhwa, sir, who's senior consultant, pediatric gastroenterology, hepatology, and Arjun Maria, sir, associate consultants. Today I'm presenting case approach to jaundice. My child patient name ABC, 7 years male, residence of Gadarbal, Kashmir, informant's mother, and date of examinations 22 May 2024, presenting with complaints of fever 21 days ago, which were subsides after 2 days, followed by yellowish discoloration of eyes 15 days back, followed by vomiting 15 days back, and for 2 days, and decreased appetite 15 days back. Relatively asymptomatic 21 prior to admission, started having intermittent fever, which were acute in onset, maximum documented of 100 Fahrenheit for 2 days only, completely relieved on taking antipyretics, no diurnal variation, not associated with rash, chills, rigors, and subsides 19 days back, followed by patient having yellowish discoloration of both eyes with dark color urine, with yellowish discoloration progressively increased over the course.
Okay, can you go back to the first slide?
Yes, sir.
So when you have a child who is presented with jaundice, what is the first thing that you want to determine?
Sir, I want to determine either jaundice firstly come or with prodromal syndromes first comes. In this case,
No, I want to know that do you know what types of jaundice can there be?
Yes, I want to know either it is conjugated or unconjugated jaundice.
Okay, so how do you differentiate between the two?
Sir, for conjugation and unconjugations, we will differentiate either it is hemolytic or hepatocellular or. Yes, sir.
How do you differentiate between conjugated and unconjugated hyperbilirubinemia based on history?
Either child having history of only icterics or pallor, or giving a history of child hemolysis rash. Either patient is giving history of any stool related to stool color changes. If child is giving history of any rash or any petechiae, then it may be unconjugated or hemolytic jaundice. If patient is giving no such any history, and history of giving only dark color urine and
Yes, you want to look at the urine color. So
yes,
in direct hyperbilirubinemia, you are using the word conjugated. So is there a difference between conjugated and direct hyperbilirubinemia?
Sir, direct indirect, sir, in this case, sir, either it is the hepatocellular or an obstructive. And if it is hepatocellular jaundice, then it may be a patient present with an history of jaundice or
Okay, let me rephrase. What is the importance of urine color in a child who presents with jaundice?
Sir, urine color differentiate if either urine color is dark yellow color urine or any other cola colored urine. In this case, if there is cola colored urine, there may be a chronic history of jaundice related to liver chronic history. If color have child or is there having heavy dark color may be related to jaundice or any other sepsis and dehydration status. In this case, in that case, may be present with dark color urine. We will further differentiate according to history, sir.
So whenever a child presents with jaundice, the first thing to determine is whether the child is having direct hyperbilirubinemia or indirect hyperbilirubinemia. In direct hyperbilirubinemia, you have to ask for history of dark colored urine or high colored urine. Whereas if the child has indirect hyperbilirubinemia, his urine will be of normal colored. So what does this child have?
So this child has a dark colored urine at that time, sir.
So according to you, this is direct hyperbilirubinemia.
Hyperbilirubinemia. Yes, sir.
So direct hyperbilirubinemia can be because of two reasons. Either it will be a hepatocellular cause, or it can be an obstructive or cholangiocytic cause. Because the
Yes,
liver
sir.
is predominantly made up of two types of cells. One is hepatocytes, and another is cholangiocytes, which from the bile ducts. So how do you differentiate between whether this direct jaundice is because of a pathology which is affecting the hepatocytes, or is it because of a pathology which is affecting the bile ducts or the cholangiocytes? So that is the next step. First, you determine what type of hyperbilirubinemia is there, direct or indirect. Then, when you determine that it's a direct cause, then you determine if it's hepatocellular or cholangiolar. So how do you differentiate between the two based on history?
Sir, for differentiating both of you, agar if there is a hepatocellular, there may be history of acute history and history of any drug intake, or with child presenting with vomiting and pain in hypochondrial regions, and in obstructive case, a child may be present with bile vomiting and history of any previous surgery, even any needle pricking, and or any pruritus. Mainly, the pruritus is the main symptom in obstructive jaundice, with along with the abdominal pain.
So what
And
is
the
the
example,
importance of stool color in differentiating between these two
sir,
causes?
on obstructive stool color is, sir, in the obstructive jaundice, stool color is clay colored stool, sir.
Yes, very good. And in hepatocellular cause,
Sir, it's the
jaundice,
normal color stool and dark color unit, sir.
where do you see pruritus?
Sir, if for seen pruritus on body surface, is there is scratch marks are present, it may show
In which cause do you see pruritus?
the obstructive jaundice.
Very
In the
good.
obstructive, it may be pruritus.
And in which cause will jaundice appear first, earlier as compared to the rest of the symptoms?
Sir, in the hepatocellular jaundice may first priors, then the obstructive jaundice, sir.
No, in obstructive causes, jaundice will be the predominantly and first symptom, whereas in hepatocellular, it will be preceded by a prodrome of other symptoms such as fever, anorexia, vomiting, etc.
Yes, sir.
So, what does this child have?
So this child has actually proceeded prodromal syndromes with fever, with loss of appetite, anorexia. After that, child started fever was intermittent, and after subsiding of the fever, child was followed by the yellow discoloration of eyes,
So,
and
very good.
having jaundice.
So, according to you, this child is having direct hyperbilirubinemia, and which is most likely to be what? Hepatocellular or
Hepatocellular, sir. Hepatocellular, sir.
hepatocellular, because it was preceded by prodrome. It did not have any. The child did not have any pale colored stool. He had normal pigmented stools, and he did not have any pruritus.
Yes.
Okay. Okay, now we can go ahead.
Relatively asymptomatically,
Yeah, next
should I?
slide. We have seen this slide. Go.
He also developed vomiting for 2 days, 3 episodes per day, occurred mostly after food intake, contained digested food particles, not associated with blood or mucus, which differentiate from the any other history of the cause jaundice and obstruction, not bile stain, which ruled out for obstructive jaundice, and non-projectiles, which shows the no any CNS involvement in case of if it is it having projectile vomiting, and child followed by loss of appetite by 50%. So I asked the child mothers about the loss of appetite before starting of illness, and after starting illness, the child appetite loss by 50%, and associated with nausea and excessive tiredness, lethargy. Child was lethargic and excessive tired.
So he developed fever, vomiting, and decreased appetite, followed by jaundice. Okay. So what are you thinking right now? What does this
Sir,
child have?
So child is have conjugated hepatitis, acute episode with prodromal symptoms are present, and there is no other symptoms regarding after that, no stool colored pigmentation or any yellowish discoloration, only dark yellow colored stool, which will show acute in history because fever subsides after starting jaundice, and which are prodromal symptoms are present, and hepatitis decrease.
What
And
causes of hepatocellular jaundice are you thinking in this child? What can be the causes?
sir, in this hepatocellular jaundice, maybe
What are the causes of? Hello?
so,
Can you hear me?
yes, sir. Sir, yes, sir.
So what are the causes of, let me rephrase, hepatitis?
Sir, maybe causes of hepatocellular, maybe drug ingestion history, any history of hello,
Continue. What are the most common cause?
sir, abdominal pain.
No, cause of hepatitis. What are the common causes of acute hepatitis?
Uh, Sir, it is maybe in many infection,
Yes, what infections?
hepatotropics or non-hepatotropics, and
Viruses, you mean to say?
hepatotropics, maybe virus due to
Yes,
hepatitis A, hepatitis E, sir,
C,
hepatitis
very
B and
good.
C or D, and
So C will not
non-hepatotropic.
cause acute hepatitis. C will cause
It will
chronic.
cause chronic hepatitis, yes, sir.
Yeah.
Most common cause is the hepatitis A, mostly in
Yes.
children, and hepatitis in adults, and acute history, having hepatitis A have acute history 2 to 3 weeks. And non-tropic causes are many others, cytomegalovirus. This mostly common in autoimmune deficient children, Epstein
Very
Barr
good.
virus, parvovirus, adenovirus. Apart from that, dengue fever also presenting like malaria, leptospirosis, but
Very good.
leptospirosis with scruff typhus are other causes for.
Okay. Did you say typhoid fever, which is also
Yeah,
important?
enteric fever also present, like sir.
Okay. And then after infections, what can be the
Sir,
other
after
causes?
infections are medications, any history of medications, or maybe cause the hepatitis.
What medications can cause
Sir,
hepatitis?
medication, anti-tubercular medication,
Very good.
anti-convulsants medications can cause hepatitis.
Very good.
And sir, in anti-tubercular, rifampicin, pyrazinamide, anti-convulsants in maybe due to the phenytoin valproates. Many of antifungal may be cause hepatitis, ketoconazoles, antibiotics, erythromycin, and
This child
tetracycline.
was taking paracetamol for fever. So was he taking it in high dose
No,
or?
sir, this child taking only for 2 days, but not in
Okay.
excessive dose because
Mhm.
fever was intermittent and only for 2 days. And that's why child is taking for 2 days only, which may not cause the hepatitis for that.
So what is the typical prodrome which has been described for hepatitis A virus associated?
So typical
Symptoms?
prodromes having the nausea, vomiting, and with jaundice and right hypochondrial pain, and be followed by
Prodrome is that which occurs before the jaundice.
so that is fever and anorexia and loss of appetite, sir.
Okay. Anorexia and loss of appetite. Yeah. So these are the common symptoms which precede the onset of jaundice by around 5 to 6 days. Okay. Then go ahead. So in this case, what do you think is happening?
So in this, the fever, after fever side prodromal symptoms are present, and it is acute onset and with urine color yellowish, and preceded by after the starting of jaundice, fever subsides and progressively increased jaundice, and
Okay.
most probable acute viral course.
Okay, go ahead.
And now I'm taking history. I'm discussing history and positive or negative history to rule out the
Yes.
causes. And in the neck complication followed by complications, there is no history of altered sensorium, no history of headache, seizures, or irritability, or the altered sleep cycle. To rule
Why are
out
you
this,
asking for this?
sir, to rule out the CNS complications related to the hepatitis or to altered sleep cycles are altered in this case, and day sleepiness is more. And
In
history of
in what
yes, sir.
complication does that happen?
CNS complication in Wilson disease, sir, may be present. This type of presentation may be present, sir.
What is
And
hepatic encephalopathy?
Sir, in hepatic encephalopathy, there is presence of the abnormal behavior and lethargicness and hypotonic be present with hepatic encephalopathy with altered behavior, with most
So
probable
there are
irritability more.
so there are different stages of hepatic encephalopathy. The
Yeah,
first
sir.
stage is altered sleep-wake cycle.
Yes, sir.
Okay. So
Ji, sir.
if the child has these symptoms, so is this a good sign or a bad sign? And what does that suggest if the child has these symptoms?
So
Altered
that is,
sleep-wake cycle.
if they have hepatoencephalopathy present, then symptom if present, their child has poor prognosis and bad signs.
It suggests that the child is going into acute liver failure.
Liver failure, yes, sir.
So why did you ask for no history of cola-colored urine?
Sir, it will differentiate cola colored urine for autoimmune history या फिर or Wilson disease, and no history of bleeding from any sites to rule out the any hemolysis in this case of the Wilson's disease, and no abdominal distension to rule out of the chronic history.
From where did you get Wilson's disease?
Pardon
We
me,
were
sir.
talking about acute hepatitis. No, we are currently talking about complications which can happen
Okay,
in
sir.
a case with acute viral hepatitis. So first you have to look for hepatic, if the child is going into hepatic encephalopathy. If the child is going into that, then he will present with irritability, altered sleep-wake cycle, persistent inconsolable cry, altered sensorium. He may throw a seizure in the later stages of hepatic encephalopathy. Second
Ji, sir.
complication you want to look for is coagulopathic associated bleeding. Although it is rare in acute liver failure, but still around 10% of patients with acute liver failure can have bleed. So second
Yes,
should be no history of bleeding from any side. What is the
yes.
most common bleeding associated in a child with acute liver failure?
Sir, in acute liver failure, bleeding associated from epistaxial bleeding, mucosal bleeding, ulceration, or GI bleeds may be present.
So upper GI mucosal bleeds are the most common. Okay.
Okay, sir. And no
Uh,
history of abdominal distension.
why do you want to ask for abdominal distension?
It due to acute liver failure to rule out to liver failure. If there is abdominal distension with the edema or ascites, it may be child may go in the liver failure. And there is positive
So
history of
acute liver failure is usually not associated with
abdominal.
ascites or gross abdominal distension. Only in children who are already malnourished, if they develop acute liver failure, then they go and go on to develop ascites. And if
In
you look
that,
at the studies which have been published from India, around 30% of our children, only 30% of our children develop ascites, acute liver failure children. If a child presents with jaundice with massive ascites, you consider chronic liver disease instead of acute liver failure. So there's a difference between these two.
okay, sir.
No need to
Should I
take. Yeah.
should I proceed,
History
sir?
of outside food intake. Why did you ask that?
Sir, to rule out this, in this case, child having history of to most probable hepatitis may be fecal-oral route hepatitis A. In this case, the his all his family also taken outside food two weeks ago, and after that, all symptoms are started, sir. 2 to 3 weeks ago, actually, they taking outside history and taking food in street food. After that, symptoms started to the child, sir.
Okay.
On
No history of body ache, joint pain, swelling. Why
this
did
is
you
a
take history of body ache?
So in this case, if there is autoimmune hepatitis, it will be present like body ache,
Autoimmune
joint.
hepatitis will not have body ache. And why are you thinking of autoimmune hepatitis? Can autoimmune hepatitis present like this acutely? Hello?
No, sir, no. It will present chronically, sir. Or maybe sometime acute on chronic, maybe presentation may be like that, body pain or joint pain.
So with autoimmune hepatitis, in Indian studies, 60% of them present as chronic liver disease, and only 10 to 20% present as acute hepatitis. Rest will present as acute and chronic liver disease. But in Western series, a larger percentage, around 30 to 40% will present as acute hepatitis, but not in India. So it is not a common presentation of autoimmune hepatitis is not like this. An autoimmune hepatitis, most common associated extrahepatic manifestation would be autoimmune hemolytic anemia, followed by gastrointestinal symptoms like diarrhea and then joint pain, swelling, rash. Okay. And the
Okay,
most
sir.
common rash in autoimmune hepatitis is acneiform rash.
Yes, sir.
Okay.
And no
So,
history of no history of pruritus to rule out the obstructive jaundice and any scratch marks on the body. And there is no history of needle pricks and blood transfusion to rule out the any other hepatitis, hepatitis B, or any chronic history, and acute or chronic hepatitis may be present like that in this case, sir.
so you mentioned no pruritus. Suppose this child had pruritus. What would you think of then?
So maybe pruritus, we will rule out the other history. If with pruritus, child present with colors change of the stool, then we will think about that it may be obstructive. If only child has pruritus, low pruritus, maybe other reason may be present. The
So what obstructive causes will you think of? The child is presenting with fever, jaundice, pruritus, and pale colored stool.
So, sir, maybe it is due to cholangitis and any scolioidal cyst may be present with
Yes,
like
very good.
pruritus.
Polydocal cyst. You think of polydocal cyst. Okay. Okay,
And
go
but
ahead.
apart from
Yeah.
that, it may be present with the acute liver
Mhm.
tenderness and mass and pain in abdomen with jaundice, sir.
Yes. So what is the triad of polydocal cyst?
The triad is colorectal triad had a jaundice, pain in
Hmm.
hypochondrium region with abdominal mass, palpable mass.
Okay. And most common presentation of polydocal cyst?
Sir,
At
most
what age
jaundice,
group do they present?
sir, at age, don't know, sir. It only present in 10 to 20% peoples, but exact the age I don't know, sir.
Okay. So polydocal cyst will present usually around 5 to 6 years of age with abdominal pain, with a diagnosis of dilatation of the biliary tree based on which is seen on an ultrasound, which we get for a abdominal pain. So
Okay, sir.
this triad which you mentioned will be seen in only around 30% of the patients.
Okay, sir.
So, and if this child had indirect hyperbilirubinemia, suppose he had a normal colored urine and he had fever with jaundice with normal colored urine, what would you think of then?
Sir, I will think, sir, it is present with the only prodromal symptom or apart from other
If the
symptoms, maybe.
child had fever, URI, and then he developed jaundice and is passing not high colored urine, normal colored urine.
And maybe it is due to drug intake, sir.
Drug intake. Can you think of any causes of indirect
Sir, indirect
hyperbilirubinemia
maybe due
precipitated
to
by fever or infection? Okay, we'll go ahead.
and no history of jaundice in the past.
Hmm.
And treatment history, child has treated for fever, paracetamol taken for 2 days only. And for vomiting, he has taken syrup Ondem nearby hospitals.
Okay. Suppose this child had history of jaundice in the past. Suppose he had a history, the mother says that 1 year back also he had jaundice, which lasted for 2 to 3 months and then subsided on its own. And now again he has developed jaundice associated with fever, anorexia, and vomiting and whatnot. Then what would you think of?
Sir, if child having and history of previous history of jaundice, then we will
Hmm.
think about that acute and chronic history. It may be proceeded in previous. If there is previous history of jaundice, then it child we will think that child will go in the acute liver failure, which procedure
Not
which have.
necessarily. Some children present with 2 to 3 episodes of jaundice without going into acute liver failure. What cause will you think of? That what is happening in the liver? What is the etiology of that jaundice, repeated episodes of jaundice? I want to ask why this history is important. You have taken this history of no history of jaundice in the past, and you should
जी
also
sir.
know the significance of this history. If there was jaundice in the past, what would you think of then?
Then we will think about if jaundice present, then we will also rule out other symptoms. Either child having a history of low HB or anemia along with the jaundice, to rule out other if there any transfusion that time, or is there any multiple admissions and needle pricking, unhygienic needle pricking, and aseptic precautions should have not be taken. Those
So, what
that
etiologies can choledochal cysts present with multiple episodes of jaundice which subside after some treatment? Like
pardon
if
me,
the
sir.
child had choledochal cyst and then developed jaundice and received antibiotics for the same and became normal for the intermittent period and then again developed jaundice. Can autoimmune hepatitis have a relapsing remitting course? So autoimmune hepatitis also has a relapsing remitting course.
Okay, sir.
And they can remit on their own even without any treatment. And then later on, after a few months or a few years, they can again present with jaundice. But in the interval period, they'll still have deranged LFT in the form of persistently raised transaminases, even though the bilirubin has normalized, may have normalized or reduced, but other liver parameter function test parameters will still remain deranged. Okay.
Okay, sir. Okay, sir. Should I proceed, sir?
Yes, proceed.
Family history. No similar complaint in the family, like jaundice. No history of any neuropsychiatric illness or liver disease in family.
Why are you
And
asking for this?
sir, to rule out the and autoimmune or any other chronic disease related to
No, why
family.
did you ask for neuropsychiatric illness?
Sir, in the
Hmm. Go ahead. Why did you ask for neuropsychiatric illness?
pardon me, sir.
What liver diseases run in the family?
Cholangitis.
Why would cholangitis run in the family? What are inheritable liver diseases which can present with acute hepatitis?
So,
So very rarely fulminant Wilson's can present with acute hepatitis, although it is not a very common presentation. Only around 10 to 20% of Wilson's disease will present with acute hepatitis, like a picture like
sir.
this, and a child going into acute liver failure.
Okay, sir.
Okay. Otherwise, no similar complaint in the family. If the child, if the family has eaten some contaminated food from outside, then there would be similar such episodes in family members. That could be one cause. Okay.
Yes. Okay, sir. Child has birth by sixth on order and having a 5 siblings. And
Mhm.
older sibling is 24 years, and child is birth by sixth order, 7-year age, and antenatal and natal history not significant in this case. Child was born to 27-year female, para 6 para, 38 completed week of gestation, LSCS. Birth weight was 2.7 kg and cried immediately after birth with no NICU admissions.
So
And
why are you giving such a detailed birth history? The child is 7 years old now, right? And he has been normal in between
sir, if
for
there is
seven
any
years.
at that
Now,
time, if there is congenital problem was present or any history of jaundice at that time, or multiple history between the uh, birth and the
no,
up to
but the
age.
child was normal for the past 7 years. You said past history is not significant.
Yes, sir.
So, what is the need for such a detailed birth history?
Okay, sir.
Okay, go ahead.
Developmental history, child attain all developmental milestone at appropriate time, and currently studying in the nursery class, and with good academics as said by child is immunized date till according to National Immunization Program. But child not received hepatitis A vaccines. BCG scar were present on the left shoulder, sir.
So what are the, go back.
Yes.
What are the vaccine preventable causes of hepatitis?
Sir, if child having taking hepatitis A injections, then
Yes.
it is 100%
What
chances child may not develop hepatitis in futures.
the vaccine has a good efficacy. What are the two types of hepatitis A vaccines? And what is the dosing and schedule?
Sir, hepatitis A vaccines are dosing the 0.5 ml intramuscularly, and it is hepatitis A vaccine two types like Havrix, which is given, or a vaccine, sir. Havrix is less than 18 or less than greater than 18 years. If less than 18 years, then we will give 0.5 ml. And if child having greater than 18 years, then we will give 1 ml, sir. And in vaccines, if child is less than 15.5 ml, and if child is greater than 15 years, we will give the
How many
0.5
doses will you give? And what are the two types? You still haven't said. Havrix is killed or live vaccine?
So it is the live attenuated vaccine.
Havrix is live.
No, sir. Havrix is the killed vaccine, sir.
Okay. And
Activated.
how many doses?
So 2 doses we will give 6 months apart, sir. Intramuscular or maybe in deltoid, sir.
And how many doses of the live attenuated vaccine?
So for live attenuated, we will do subcutaneously, sir.
Doses? Single
Doses.
dose?
For a single dose for greater than 1 year age and 0.5 ml, sir.
Any other virus which has a vaccine against it which can cause hepatitis?
Hepatitis B.
Okay, very good. What is the National Immunization Program schedule for hepatitis B vaccine?
Sir, hepatitis B, for hepatitis B vaccine, it is the one giving at birth and at 1 month, then 6 months, or maybe other schedules which are 6 weeks, 10 weeks, and 14 weeks, sir. And
Yes,
after
this
that,
is the National Immunization Program schedule for hepatitis B vaccine.
B vaccine. Yes.
So how many total doses do we give?
So 3 doses, sir, and are followed by booster doses, sir.
No? Can you again say the schedule of
Sir, hepatitis B birth at the birth,
yes.
and
Then
after that followed by. I'm audible, sir?
yes, you are audible.
After birth and 6 immunization after birth, and at the 6 week, 10 weeks, and 14 weeks.
So total 4 doses, right?
Yes, sir.
Okay. So why do we give the 0 dose?
Sir, to prevent the hepatitis B vaccine has a parental vertical transmission. To prevent that, we will 0 dose or within 12 hours of the birth, sir.
Okay, continue.
Dietary history using 24-hour dietary recall method during pre-illness. Child approximate dietary intake is around 1404 kilocalorie per day and 39 gram per day proteins. Actually, child has Muslim, but he is not daily basis not taking any chicken. So that's why a mother told me dietary history according to that. And morning he's taking rice with 2 katori with 2 spoon ghee in that.
Okay, so dietary history is adequate according to you. Right?
Yes, sir.
Okay. Pre-illness, right?
Yes, sir. After the illness, the child diet reduced by 50% almostly.
Okay. So why? So what are the common mistakes which people do when children develop acute viral hepatitis regarding the diet?
So regarding diet, it is most important because it will show prodromal phase also and differentiate from the acute illness. If child is already not taking and diet properly, so we
Hmm.
can think about the weight reduce or other symptoms or other chronic disease may be affect. If in this case, child is appetite is normal before the
Let me
starting of this.
rephrase. Should there be dietary restrictions in acute viral hepatitis? Yeah. Should we restrict the diet in
No, no, sir, no
fats
restriction.
or
No, sir, no restriction of any diet, but only no restriction, sir, no restriction.
okay, unrestricted diet? You can give all the ghee
Yes,
and
sir.
that you want. Okay, go
Yes.
ahead.
Socioeconomic history, product of non-consanguineous marriage, birth by order 6, nuclear family of total 8 members, 2 adults, mother, father, and 6 children, including 5 siblings. Father is shopkeeper by profession, 5th pass, mother is housewife,
Okay,
5th
go ahead.
pass.
Go ahead.
Okay, sir. According
Go
to
ahead.
Kupuswamy, it is the upper
No,
lower
go
class.
ahead. Okay, Apollo.
And summary wise, 7-year male child having prodromal fever, followed by progressively increasing jaundice, followed by vomiting and loss of appetite, without any symptom of encephalopathy or underlying chronic disease, may be due to acute viral hepatitis.
No, acute. So you're saying that this is direct hyperbilirubinemia,
Yes,
most
sir.
likely hepatocellular, without any signs of, without any symptoms
Encephalopathy.
suggestive of acute liver failure. So what is the
Yes.
definition of pediatric acute liver failure?
Sir, if child having a acute liver failure with presenting with the any chronic history or any in PTINR greater than 1.5 with or
Yes.
without encephalopathy or greater than 2 without any
Mhm.
encephalopathy or child
Mhm.
jaundice will not be correct with after giving the vitamin K injections.
Mhm.
That's it.
No, this definition is biochemical evidence of acute hepatitis with INR greater than 1.5 along with hepatic encephalopathy or INR more than 2 even without hepatic encephalopathy, which is not correctable by vitamin K without any evidence of underlying chronic liver disease.
Okay, sir.
So what symptoms will suggest an underlying chronic liver disease?
Sir, in chronic underlying child having a prolonged jaundice and with hemolysis or any signs of the failure or and uh, greatly raised SGPT, SGOTs as
What
compared to.
symptoms will suggest an underlying chronic liver disease in a child who is presented with jaundice? That,
Sir, child having the encephalopathy, irritability, and
that can happen in
lethargy,
acute liver failure also.
and sir, hemolysis may be present in that case.
Not necessarily. Why would hemolysis happen? So if a child has abdominal distension with ascites,
Yeah, sir, mainly
or if he
ascites.
has failure to thrive,
Yeah, sir.
that can suggest an underlying chronic liver disease. Okay,
Okay, sir. Okay, sir.
so okay, go ahead.
And according differential diagnosis, viral hepatitis may be hepatotropic or non-hepatotropic. In this case, there is acute viral absence may be caused by due to hepatitis A virus, and
Hmm.
we rule out non-hepatotropic virus because fever subsides. If
What
fever
history would suggest a non-hepatotropic virus?
Sir, if the fever present or if Epstein-Barr virus present, then it will present with swelling and throat congestion. If it is present by autoimmune, then it may be acneiform, acne is present. And
So
if
what history will suggest that maybe the child has a non-hepatotropic virus? What is
so
that?
it may be present with the, if non-hepatotropic present, it may be present with the splenomegaly, ascites,
No, no, no,
and
no. No, no, no.
or it may be other symptom of hemolysis, encephalopathy, or and coagulopathies may be present with other symptom, persistent pain or fever, and followed by jaundice, or any GI manifestation, yeah, lethargic, yeah, so
Yes. Certain enteroviruses will present with diarrhea, although they can happen in hepatitis A also, but more commonly associated with enterovirus. Adenovirus will have URI symptoms followed
yes,
by
sir.
hepatitis, right? Parvovirus B19 will cause hepatitis, but it will be associated with sudden onset of pallor because it causes red cell aplasia. So these clues which you get in the symptoms can point towards a non-hepatotropic virus. Why have you included autoimmune hepatitis? What are the symptoms suggestive of
But
that?
if autoimmune symptom may be present, if there are multiple episodes are present, then even autoimmune symptoms can be included.
So was there any pointer towards autoimmune hepatitis in this case?
No, sir. Other any pointers will not show any autoimmune history, and because in autoimmune, sir, only symptoms are also central lobar necrosis may be present, and
But it
it
was,
present
I'm talking about
conditions.
symptoms. We're not talking about liver biopsy.
No, sir. No any encephalopathy present. No joint pains.
Right. And what about Wilson's disease? How will
And sir,
fulminant Wilson's present?
if sir, it will present with the hemolysis or
Right.
any chronic disease and
So what about a tropical infection causing this hepatitis? Could there be a tropical infection like enteric fever, which you mentioned before, or scrub
You mentioned,
typhus, which cause this?
yeah.
sir, if tropical infection cause fever will persistent, and apart from that, there are many hemolysis and itching, rash may be present. Other symptoms like upper respiratory tract infection may present.
They're saying that
And
fever was not there, and that is why.
okay, sir.
You're saying that there was no fever, and that is why you're not considering these infections.
Yes, sir. Yes, sir. Yes, sir.
Fever was only for a short duration.
Yes,
Okay.
sir.
Okay, go ahead.
So above finding in history, I would like to start examining with abdominal
Yeah.
symptoms.
Proceed with the examination.
After taking parents' consent, child was examined and conscious, alert, oriented, cooperative, sitting comfortably. This
So
shows
what does
that
this rule out? Yeah, conscious, alert,
this
oriented.
suggests that the child having no CNS manifestation, or neuropsychiatric illness, to rule out chronic disease or any Wilson disease which may affect, and there is no
No.
complication
You want
of.
to look at hepatic encephalopathy. If the child
Yes,
has
sir.
hepatic encephalopathy or not.
Yes, sir. And vital temperature 98.6, pulse 104 per minute, regular, all no radiofrequency delay, with all peripheral pulses palpable, with respiratory rate 24 over per minute, thoracic type. BP is 100/60, showing no any sign of shock, or SpO2 98% at room air, capillary filling less than 3. Child has icteric present, no pallor, clubbing or edema, and no sign of lymphadenopathy.
So what are the signs of chronic liver disease on general physical examination?
Sir, child on chronic child showing.
You tell me the anthropometry. Where is the anthro?
Sir, further.
Icterus and pallor and clubbing. You have to tell me the anthro after vitals.
Okay, sir.
Okay, so tell me the signs of chronic liver disease on
Sir,
general
if chronic,
examination.
if the chronic liver disease present, then it will present with prodromal symptom along with
What are
the
the signs of chronic liver disease on general physical examination?
child having less jaundice as child will present with myopathy, sir, hemolysis.
Arun,
Anji, sir.
start from head to toe and start describing various symptoms of signs of hepatocellular disease. Head to toe. अरे तुमने स्पाइडर नीवाई सुना है, कापुट मेडिसी सुना है?
Yes, sir. Yes, sir.
तो वो बोलो ना सारे.
What do you look for in the what are facial telangiectasias?
Pardon me, sir. Can't remember at that time.
Acha. Palmar edema, clubbing, facial
Yes, sir. Clubbing,
telangiectasias, spider
yeah.
nevi.
Yes, yes, sir.
Okay, you need to read up on those.
Okay, sir.
And after vitals, you have to tell the anthropometry.
Yeah, sir. I remember. Palmar erythemas, apart from the facial telangiectasis, as sir said,
Yes.
clubbing in biliary cirrhosis, yeah, scratch marks may be present, pruritus. Apart from that, short stretchers or rickets and history of progressive familial cholestasis.
प्रोग्रेसिव फेमिलियल कोलेस्टेसिस। अच्छा, ठीक है, आगे चलो।
General physical examination hairs normals, eyes yellowish discoloration, upper bulbar conjunctiva, no KF rings present, and oral cavity tongue normal or no pharyngeal erythema, tonsils to rule out chronic disease or any involvement of Wilson's or and chronic, no gum bleeding, and two other causes may cause like dengue in this case, and no history of skin dryness, BCG scar present, no ulceration present, no rash or petechiae present, and no pulmonary arrhythmias present, as you rightly said, to rule out chronic disease, and external genitalia normal and circumcised penis. Anthropometry wise, child weight was 20 kg and height was 122 centimeter, lies between jet score of 50 to 70 centiles, and basal metabolic index is 14.2, lies between 25 to 50 centiles according to CDC chart. And
the child has normal anthro.
yes, sir.
So
And
this suggests that he is unlikely to have an underlying chronic liver disease, and this was
yes,
most likely an acute episode. Okay.
yes. On systemic
General
exam,
examination. Yeah.
per abdomen examination, child was examined in supine position, both leg flexed at hip joint. Inspection, shape normal. No
Why do
umbilicus
you
is
flex the lower limbs?
to sir, relax the muscle, abdominal muscle, to
Yeah, very
palpate
good.
for
Yeah, good. Go ahead.
inspection. Sir, umbilical is in center with no discharge, no scar marks or dilated vein to rule out portal.
Why did
And
you ask for discharge, see for discharge in the umbilicus? Okay, go ahead. Do you expect some discharge to be coming out
no,
from the
sir, no expectation at that point, sir.
no scar marks, no visible dilated veins. Okay, no visible pulpation.
On palpation, superficial, no local rise of temperature, no tenderness. Deep palpation, liver is palpable in right hypochondrium, non-tender, soft, round margin, smooth surface, 4 centimeter below costal margin, right clavicular line. Spleen is not palpable. And on percussion, upper border dullness in the fifth right intercostal space, full expression with lower border extended dullness extended 6 centimeter below right costal margin with liver span of 14 centimeter. No fluid, no free fluid present. To rule, this will shows that it is acute condition. Child is not in liver failure because
So how
if
do you check for free fluid?
the free fluid we check by puddle sign or by shifting dullness. The puddle
Okay.
sign or by ultrasound. By
No,
ultrasound, by
clinically,
puddle.
we are talking about clinically.
Clinically, if the child have puddle sign, if 1550 percussion 15 ml, even 15 ml fluid will present, we can differentiate. If child has shifting dullness, then it will show the child having fluid and having ascites, which indicating child is going to in liver failure.
And in gross ascites, what sign will be positive? What sign will you do if the child has
Sir, in
gross?
gross ascites, the child having abdominal distensions with pulsatile veins, visible veins on the abdomen, and
Fluid
umbilicus
range will
was
be
stressed.
positive in a child with massively gross ascites. Okay.
Yes, sir. And auscultation, vowel sound hears normal.
Okay, go ahead.
Other symptom examination system are respiratory
So
are
in this
normal.
you found hepatomegaly.
Yes,
Go
sir.
back. Yeah, go back.
Yes, yes, sir.
So there was no spleen. So what if spleen had been palpable?
Sir, if
If you
it
find a
will
child who has come with jaundice with hepatomegaly around 4 centimeters below costal margin, span of 14 centimeters, although the span is normal, and a spleen is you get a 5 centimeter spleen. What causes would you think of then?
then, sir, we will think about that. Is there any other causes? Hemolysis, malaria. In that case, we can palpable spleen, and hemolysis, if there is present there, it will present like
So hemolysis
palpable
have
spleen.
conjugated, मतलब direct hyperbilirubinemia or indirect?
Sir, it will be indirect hyperbilirubinemia. Yeah, in
So
the
this
direct.
child has direct hyperbilirubinemia. No? So what causes will you think of a palpable spleen in child with direct hyperbilirubinemia? Can viral hepatitis have a palpable spleen?
Yeah, maybe sir have viral hepatitis. In case of
No.
malaria, then it palpable.
Viral
Sir.
hepatitis in 30% of the cases can have an enlarged spleen. What other causes would a palpable spleen point towards to? So in chronic
Sir,
liver disease, the spleen becomes palpable
okay, sir.
because of a chronic etiology which is causing liver cirrhosis. So if you get a very large spleen, you will also think of an underlying chronic liver disease which is causing these symptoms. Okay.
Okay, sir. Okay, sir. And CVS examination, no prominent veins or visible pulsations in precordium. S1, S2 here normal, no murmur gallops. It rules out that it is not a chronic case. In this, if chronic case, then or colorectal cyst or ascites, it will may compress the lungs or may affect the pericardial effusion like that. And
No, no,
CNS,
no.
CNS, yes,
Okay.
sir.
What are you saying that colorectal cyst can compress the lung?
No, sir. If there is obstruction or acute chronic liver failure, then it may cause ascites. It may compress the lungs and may further cause an respiratory or compromise of CVS systems. And in this case, CNS examination is also important because if there is a chronic case or child presenting with the CNS infection, then CNS findings are important. But child is
Okay,
acute
go
on.
ahead. That CNS is normal, right? You're saying.
And
Okay.
summary wise, 7-year male having prodromal fever, followed by progressively increasing jaundice, followed by vomiting and loss of appetite without any symptom of encephalopathy.
Okay.
On examination, child had normal head-to-toe examination, normal anthropometry with an icterus, presence of enlarged liver with no other abnormality, and suggesting the child having acute viral hepatitis with no sign of hepatic failure or any encephalopathy.
Okay.
Means most probable conjugated type of hepatitis.
So the approach should be whenever you get a child with jaundice, first you determine if the jaundice is direct or indirect based on symptoms of predominantly urine color. If the jaundice is associated with dark colored urine, that suggests a direct hyperbilirubinemia. Now, direct hyperbilirubinemia can be because of a hepatocellular cause or a cholangiolar cause. Hepatocellular cause will have associated prodrome and onset of jaundice, which is a bit delayed from the prodrome. It can also, hepatocellular cause will be associated, more likely to be associated with hepatic encephalopathy and acute liver failure features, whereas the cholangial cause will be associated with pruritus. Onset of jaundice would be earlier as compared to the other symptoms, and it will also be associated with clay-colored stools. Okay, and
Yes,
then
sir.
you determine the child has a hepatocellular cause, then you should determine if the child has acute liver failure or he is just an acute hepatitis. In acute liver failure, the child will also have hepatic encephalopathy, which will manifest as increased irritability, altered sleep-wake cycle. And meanwhile, keep an open mind for an underlying chronic liver disease,
Okay,
which
sir.
will have other symptoms like failure to thrive, repeated episodes of jaundice, or history of jaundice in family members, or joint pain, which is associated with autoimmune hepatitis, or any evidence of autoimmune hemolytic anemia. Okay.
Yes, sir.
Do you have the investigations or?
Yes, sir. Investigation done in Sir Gangaram Hospital. CBC's HB is 11.3 and TLC 5060 with neutrophil 60 and lymphocyte 34 and platelet counts is 1.74. This is significant if there is hemolysis or chronic disease, then it will platelet will counts down below the normal range. But in that case, platelet is within normal limit. And after that,
Okay.
important investigations are bilirubin and total and direct bilirubin.
So no, thrombocytopenia can be associated with acute viral hepatitis also. around 10-15% will show thrombocytopenia. But if you see thrombocytopenia, your mind should go towards a chronic liver disease, which is causing splenomegaly and hypersplenism. Okay.
Okay, sir. And important in this is serum bilirubin is on 17, it is 19.58, and direct is 14 point. And after and total bilirubin is improving after the
So what is
admission.
this AST-ALT more than 10 times upper limit of normal? What are the causes of that? 10 to 20 times
Sir,
upper
in
limit of
the
normal
if
AST-ALT.
SGPT, SGOT is 10 to 20 times increased in the acute viral hepatitis,
Yes,
and if
and
less then
what are the
and
causes?
yes, sir.
What are the causes will show a very high AST-ALT touching 1000?
Sir, other causes may be in the any pancreatic cause or any chronic sepsis or
No.
in liver.
So there are very causes which can cause AST-ALT elevation 20 times upper limit of normal touching 1000 are acute viral hepatitis,
Yes, sir.
drug-induced liver injury, autoimmune hepatitis, and ischemic hepatitis. Okay, so
Okay, sir.
remember these four causes. If you see a patient with very high AST-ALT, so you will have one of these four causes, right?
And
So GGT is normal in this case.
yes, sir.
Can acute viral hepatitis like hepatitis A present with high GGT? And if so, at what stage of the hepatitis?
Sir, if there progressively jaundice present and child is going to into the acute liver failure, then GGT may
Acute
be.
liver failure will lead to derangement in AST-ALT, not GGT. GGT is a marker of cholangiocytic injury.
Okay, sir. Yes, sir. It is always present in cholangitis, high GGT. Yes, sir.
Yeah, so can
And
acute viral hepatitis A lead to high GGT?
no, sir.
It can in later stages when the
Okay.
hepatitis A goes into the cholestatic phase. Then AST, ALT, and INR and albumin will normalize, but
Okay,
bilirubin
sir.
and GGT will progressively increase, and the child will develop pruritus at that time. Okay.
Okay, sir. Okay, sir. And PTINR is normal range within normal range in this
So this
case.
suggests that the child does not have acute liver failure.
Coagulopathy. Yes, sir.
Not
And
coagulopathy, acute liver failure. Right.
yes,
HIV is
on
positive.
HIV positive, which suggests that acute hepatitis, and on USG, liver in last 14 centimeters, spleen normal, gallbladder thickened edematous, rest of normal findings with hepatomegaly, cholecystitis with no ascites.
How did you manage this child?
Sir, there is this child is managed by properly mainly by only hygiene maintenance and proper hand washing, proper technique using food, making food with proper washing and proper good
What
quality
is the
water.
role of UDCA in acute viral hepatitis?
Sir, UDCA, sir, it will reduce the bilirubin level and which prevent further complication and liver failure. And
What is
apart
the
from that,
N-acetylcysteine and acute liver failure?
sir, NSS style cysteine, sir, if there it is drug induced paracetamol
Yes,
causing
very
acute
good.
liver failure,
Very
then
good.
it will helpful in that case, sir.
Okay, very good.
And apart
And
from
how would
that,
you manage hepatic encephalopathy?
sir, if there is hepatic
The child with
encephalopathy, we
acute
will
liver failure.
manage first but child's vitals, then we can give the lactulose to remove the it may go it will lead
Yes,
to reduce constipation, decrease the ammonia level,
very
and
good.
further we will airway breathing management and fluid management and shock management with appropriate antibiotics to prevent uh, other infections. But it's important to avoid the antibiotic which may cause the further decrease hepatic functions and prevent, and which antibiotics which cause the decrease hepatic function we will should avoid and give require appropriate antibiotic along with the
You give broad spectrum antibiotics in case of child with acute liver failure. Okay, based
okay, sir.
on the uh, local hospital or community
And
sense.
And no dietary restrictions for the acute
Yes,
acute
very
viral
good.
hepatitis, sir. That is
Good
important. And
diagnosis.
proper counseling also important, because many of time
So could
patient
this
thinks
child have
that
been managed at home if his INR was normal? Did he require admission?
no, sir. If the after the admission, if child no, no, at that time, sir, child having very low appetite and child is taking nothing, and we
Okay, so
will
you admitted him for because he had poor
sir,
oral
main
intake.
important, we have admitted the child to look for INR status. If it is deranged, it will show the child is going to acute liver failure. If child having no any such
Mhm.
episodes, then we can discharge the child and manage at home.
Okay. So Dr. Anupam,
Sir, I have a doubt. Can I ask, sir?
yes, sir.
His hepatocellular, this thing, hepatitis, such
Yes,
a
sir.
large liver is, span is not so common because hepatocellular necrosis occurs. Have you seen such a massive hepatomegaly?
Yes, sir. In acute viral hepatitis, we can have because there is edema in the
Yeah.
liver itself, so it can cause
So,
hepatomegaly.
because we have seen maximum 3 to 4 centimeters more
When the
than the
child
norm.
is going into acute liver failure,
Yeah.
then hepatocyte necrosis started, and then the liver span shrinks. That is why one of the major clinical thing which you have to do in children with acute liver failure is measure liver span at least twice a day. So you get an
Yeah.
early clue that the liver is shrinking and now the hepatocellular necrosis is happening and the child may further worsen.
Usually the span is usually 3 centimeters maximum, but here 14 centimeters. I am surprised.
14.
Okay,
So 3
thank you for.
centimeters below the costal margin, but span is set by percussion. So that is 14 centimeters.
Yeah, thank you so much.
Any other questions?
No, I've seen even in the question Q&A session, there was nothing there. Would like to thank everybody who's attended this session, and also Dr. Arjun Maria, for an excellent conduction of the class. There are so many points he brought out which were, not known to us also. So thank you very much, Arjun, and thank you, Dr. Srinivasan, for being there all the time.
One more question can I ask, sir, before you close?
Yes, sir.
Please
Yes.
go ahead.
Is there any specific treatment against hepatitis? Yeah, of course, hepatitis and see there, this thing, any specific drug has
No,
been
sir,
developed?
no specific drug, but as we say, prevention is the best cure, and we have a very good vaccine. So in India, unfortunately, it's not part of the government program, but we do have it as a part of IAP program. This child received a government scheduled vaccination, so he unfortunately missed out and had hepatitis A. So
Thank you,
that is
sir.
one issue which we have to address because now hygiene standards are improving in India. So children are not being exposed to hepatitis A early on. They are being exposed to hepatitis A as they grow older. And we know that mortality due to hepatitis A increases as the age increases.
Yeah,
In the next decade, we are expecting a lot of mortality because of hepatitis A because the virus is still in circulation, but hygiene standards have improved. So the age of exposure is increasing.
thank you, sir.
Yeah.
In
But no
fact,
specific
there is,
antiviral which we have against this
in
yet.
due course of time, there is a chance that it will be included in the immunization schedule also. So, thank you. My comment on Arun's presentation is uh, well presented, but needs lot more practice and lot more effort and lot more case presentations from Arun, because he's shortly going to appear in the practical examination. And Arun, my advice would be that daily do a presentation to your other postgraduates and senior residents so that you can hone your skills further.
Okay, sir.
Okay.
Okay, sir. Okay.
Thank you
Yeah,
very
very good
much,
advice.
everybody.
Yeah, take it seriously. Very good
Yeah.
advice.
Yeah. So thank you very much, everybody, and thank you, Dr. Srinivasan. I missed. There's a
Yes,
very
sir, I
senior
have to thank you.
another senior pediatrician, Dr. Mridu Jan Sehgal, in the audience. I've missed promoting her to the, as a panelist. Thank you, ma'am, for attending the classes very diligently and constantly you are there. Dr. A.K. Sharma also is there, who is also a senior pediatrician, one of the people who's very good in PALS and BLS and in, and pulmonology. He's very good in that. Thank you, everybody. And thank you,
Thank
Arjun.
Thank you, sir.
Good night, all of you. Good night.
Good night.